Hey, how's it going, everybody? I would just like to thank you all for tuning into my webinar today. And what I will be talking about and sharing with you guys is my herniated disc MRI before and after results. And so I know a lot of you guys have been talking about this and asking for me to do a video regarding an MRI comparison. And so I've finally put together a little bit of a presentation in which I will be sharing my results with you and talking about some of the implications as to the comparison from my initial MRI to my follow-up MRI. So to begin, guys, if you're someone that is new to this video or to hearing my story, just to go over my story quickly. If we go back to October to November of 2013, this is when I had my initial injury and pain. And so while there was a bunch of activities that I was doing that kind of led up to my injury, the deadlift, I performed a heavy deadlift with poor technique, and that was essentially just the nail on the coffin. And upon not knowing the severity of my injury, thinking it was just something very subtle and not serious, I continued to work out, continued to engage in a lot of poor movements and postures, which quickly made things worse. And the next thing you know, I was in severe and significant pain. And so on January 6th of 2014, I had my initial MRI done, in which it showed a posterior lateral disc protrusion at the L5-S1 hitting the S1 nerve root. And I was experiencing sciatica, I had muscle spasms and just significant pain, and I was very limited to what I was able to do around this time. And then through August to September of 2015, I eventually made a pain-free recovery where I was able to do a lot of activities and tasks that I previously wasn't able to do during the time of my injury and pain. So some activities that caused me pain were sitting and bending over. And so in the picture on the right was a thumbnail of an update video that I did, just showing everyone that I was able to sit and kind of bend over and that I've made a pain-free recovery. So I'm able to do these activities completely fine now without pain, and those were activities that were pain triggers of mine at the time. And then now if we kind of backtrack a little bit, guys, if we look to October to April of 2014, during this period I had no improvements, and I arguably got worse during this time. And this was because of all the chiropractors, physical therapists, and doctors I saw. The treatment and advice they provided with me did not do much other than provide maybe some relief, and arguably made things worse during this time. And so one may argue that if I actually got the proper treatment during this time, that I would have made a recovery in a shorter period of time. And that period of time could have been maybe February to March of 2015 instead of August to September of 2015 if I had that initial proper treatment at the beginning. And then on July 24th, 2017 is when I had my follow-up MRI conducted. And so this was 3.5 years after my initial MRI. And so I got it done just to kind of do a comparison to see some of the changes that may have occurred over the years, to see if how things have progressed, and maybe if there's any sort of changes that some things may have got worse, just to kind of see some of the implications and what has occurred over the 3.5 years. Now, it's important to keep in mind, guys, I just want to kind of share with you guys my prediction here leading into this follow-up MRI. And so this was a comment and question from one of my subscribers. I'm just going to read to you guys quickly. So, hey Remi, I have exactly the same MRI as yours, lateral disc protrusion on the right side at the L5-S1. I got it 6 months ago while doing deadlifts. Now, as you explained that you have almost fully recovered, I wondered that you have done an MRI recently. The reason for me to asking this question is that no pain or 100% movement doesn't always mean that you got completely healed from inside. As you've recovered in the last 3 years, I'm just curious to know if 100% healing of disc protrusion is possible or not. Let me know your answer. I'm hoping to gain knowledge and confidence from your experience in the last 3 years. Regards. And so my response to this, and it's actually a really good question, because 100% being pain-free does not always mean the disc is 100% healed. That's important to keep in mind, as has been shown in previous literature. So my response was, I actually have my MRI, I actually have my follow-up MRI scheduled tomorrow, so we'll know exactly in about a week how things have potentially progressed over the years. And yes, while I'm pain-free and I've made a recovery, I personally don't think my disc protrusion has fully 100% healed. It just got to the point where it's pain-free. That's just my opinion at the moment, but I'll know for sure after I get the MRI results. I personally believe that a disc protrusion can 100% heal. It can just take a heck of a long time, and one's recovery plan needs to be very good. So my mindset leading into this follow-up MRI guys, is that I believe that my disc protrusion regressed or just healed to the point where I had become pain-free and I didn't have any issues with bending over and sitting anymore. And I believe that it can take a really long time for disc protrusion to actually heal, and one's recovery plan needs to be very optimal and almost perfect to really get to that point, and it could just take a really long time to get to that point of healing. Now, to jump into my MRI report here, guys, which I will be sharing with you guys first. Now, keep in mind, guys, I'm not a radiologist, and I'm not trained to read MRIs. This is just my MRI, and I'm sharing with you guys for educational purposes, specifically my case, just to show you guys how things have changed over the years, how things have progressed, and maybe have gotten worse. So keep in mind, guys, though, I'm not a radiologist, and I'm not trained in this aspect. So I want to kind of talk about that before I jump into this. So January 6, 2014 is when I had my initial MRI. So the reason for my exam was right lumbar radiculopathy. July 24, 2017 is when I had my follow-up MRI. Reason for exam was just a follow-up MRI for a previously diagnosed L4 through S1 disc herniation. So the history was right lumbar radiculopathy, technique, multiplanar, multisequential, MRI lumbar spine. Report MRI lumbar spine technique, sagittal TS1, T1, T2, and axial TSE, T1 to T2 images of the lumbar spine. So what I'll be showing you guys is an axial view of the L5 disc to show you guys the changes from the previous MRI on January 6th, the follow-up MRI, show you guys what the disc looked like prior and what it looks like now. Now, it wasn't a comparison examination and my initial exam, but the July 24th, the reason for it was comparison to January 2014. So the findings, guys, I'm going to go through all the findings and everything that was reported on the MRI. So we have 4 lumbar vertebral bodies present. Bone marrow signal is heterogeneous and likely related to hematopoiesis, so smoker athlete. So I was an athlete through all my life, so just some changes within the bone marrow, and it's likely related to hematopoiesis, which is the formation of blood cells. So correlation for anemia should be completed. However, findings are likely within normal limits. So I never had that correlation completed, but as reported on the MRI, it was likely within normal limits, and I haven't really had any complications with the result of that. So findings, alignment and vertebral body heights are within normal limits. The conus medullaris identified at the T12 vertebral body. So the conus medullaris, guys, is the cone-shaped end of where the spine, it's a term that's described where the spinal cord kind of tapers off at the end in our spine. So that's usually located around the T12 to L1, L2 level, which we will see. And so the conus has normal appearance at the L1 level, and then the conus will eventually become the cauda. It goes into the cauda equina, which houses all our nerves and nerve roots from the lower lumbar vertebrae and beyond, so below L2 and beyond. And then we have straightening of the lumbar lordosis is noted. So straightening the lumbar lordosis, guys, so that's just indication that my spine had been deviated from its normal lordotic position, and it's been kind of more flattened or straight, which in theory, if this is occurring, we're going to get more stress onto my lower back, specifically into the discs and joints over time, especially if we're adding compressive loads to my spine or doing certain activities, like maybe jumping, running, or whatnot. So if we look through L1, L2, L2, L3, and L3, L4, there is a prominence of posterior aspect of the disc basis with small disc osteophyte complexes, so that being bone spurs, noted involving the lateral neuroforaminal zones. So the lateral neuroforaminal zones, guys, is where nerves travel through in our spine, and if they become narrow, they can kind of pinch nerves and we can get radicular pain occurring. So we have with mild facet osteoarthrosis resulting in mild to moderate bilateral neuroforaminal canal narrowing. So we have some narrowing on both sides, bilateral meaning both sides, neuroforaminal canal narrowing. And at L3, L4, we have effacement of the lateral recess. So we kind of have some thinning of the lateral recess occurring, but no secondary nerve root enlargement. So we have some complications occurring here, guys. We have facet joint osteoarthrosis. We have some bilateral neuroforaminal canal narrowing with the osteophyte formation of the bone spurs. So if things kind of got progressively worse, that could eventually lead to something like stenosis occurring, and we could have some nerves being pinched as a result of those canals narrowing and a result of them just becoming more thin. But if we look to my follow-up MRI now, if we look at the L1, L2, and L2, L3, we have no stenosis, no disc protrusion, no neuroforaminal narrowing or lateral recess narrowing. So in the previous report, we have some mild to moderate bilateral neuroforaminal canal narrowing. at L1 and L2, L203 and L304, but at 1L2 and L203, we don't see that on my follow-up MRI. And there's no mild facet kind of joint osteoarthrosis being noted as well, which is also important to keep in mind at the L1, L2, and L203, which would be a positive when looking at my follow-up MRI. Now, if we look to L3, L4, we have mild hypertrophic facet joint out L3, L4 and mild left greater than right foraminal narrowing without stenosis or disc protrusion. So we still have some kind of arthritic conditions going on at the facet joints at L3, L4, and then we have mild left greater than right foraminal narrowing. So we still have that narrowing occurring at the L3, L4, which was noticed on the previous MRI, but the left is greater than the right, which is indicating that maybe that left side was taking more stress, maybe that in that area or whatnot. Now through L4 through S1, we have disc space height loss noted, mild facet osteoarthrosis, symmetrical disc bulge, osteophyte formation, some mild bilateral neuroforaminal canal narrowing was identified. Superimposed on this process is a more focal posterior disc protrusion, noted facing and posterior displacing the right S1 nerve root disc, 1.5 centimeters transverse dimension, 2.5 centimeters anterior posterior dimension. There was no evidence of central canal compromise. So we see a lot of complications occurring here, guys, through the L4 through S1. We have disc space height loss noted at both levels. We have mild facet osteoarthrosis. We have a symmetrical disc bulge. We have some osteophyte formation, so some bone spurs. Some mild, the bilateral neuroforaminal canal narrowing. So both sides, we have some narrowing occurring of the canals. And then ultimately the big thing though is superimposed on all this is that disc protrusion facing and posterior displacing that right S1 nerve root. So that was what was causing me my complications. And that was kind of the most kind of significant issue that was really causing me my pain. If we look to my follow-up MRI now, the L4 through L5, we have mild degenerative facet joint at L4, L5, and mild annular bulging eccentric to the left, mild bilateral foraminal narrowing, and perhaps minimal left recess narrowing without stenosis. So we have some degenerative changes of the facet joints at the L4, L5, which was indicated on the previous report. So we have some mild annular bulging, eccentric, so unusually to the left of the annular bulging a little bit, the L4, L5. Mild bilateral foraminal narrowing, so we still have some narrowing occurring, and we have perhaps a minimal left lateral recess narrowing without stenosis. So I think an important thing that we see with the previous report and the follow-up is we do not have that symmetrical disc bulge. As we previously indicated, we just have some mild annular bulging kind of unusually to the left, which would be a good indication, but there hasn't, I wouldn't say there's been anything significantly that's changed over the 3.5 years at the L4, L5. But now if we look to the L5S1, we have mild degenerative facet change. So we still have some kind of arthritic kind of facet joints going on there at the L5S1, and that was previously reported on the previous MRI. And we still have that broad-based posterior lateral disc protrusion, and this extends to the right lateral recess and encroaches on the right S1 nerve root and the right lateral recess, no stenosis or foraminal narrowing identified. So we still have the facet kind of joint issues going on at the L5S1, and we still have the posterior lateral disc protrusion that exists at the L5S1 and is extending into the right lateral recess and encroaching on the right S1 nerve root and the right lateral recess. So now, keep in mind, guys, I'm not a radiologist, but if we look to the previous report, it was displacing the right S1 nerve root, and encroaching was the term that they used to describe it in the current MRI. So encroaching and displacing, they are synonyms for each other, but in radiology, they may be defined in different terms, or they may be used kind of differently to describe different extents of maybe the disc hitting the nerve root or not. But the important kind of takeaway from this, guys, is that disc protrusion still exists. We do not have any foraminal narrowing identified, which would be good in theory to see that, but because as it was previously indicated on the previous report, so that would be good. Now keep in mind too, guys, another thing is that there are two different radiologists here examining or looking at my MRIs from 2014 to 2017, so we don't have the same individual, which is a bit of a limitation because they may have different opinions on what they see with regards to the images. That's always something to keep in mind and consider. So let's look to the opinions. L4 through S1 level, a broad-based posterior disc protrusion is identified in the facing and posterior displacing the right S1 nerve root and coming in contact with this area. No central canal compromise identified. There's also minimal effacement of the lateral recess, but no secondary nerve root enlargement is noted. In the opinion on my most recent MRI, right posterior lateral disc protrusion at the L5-S1 level, encroaching on the right S1 nerve root in the lateral recess, correlate clinically for right S1 radicular symptoms. Similar findings were described in the previous MRI from 2014, but I cannot retrieve this for comparison from the hospital's electronic drive. So, two important points here, guys, is that the disc still seems to be very close to that nerve root, if not maybe very close to that nerve root and causing potential complications based on what the radiologist believes from the findings of the anatomy. And there were the similar findings were reported into my previous MRI report. But now it's important to keep in mind this was not a true comparison, because if you look at the last kind of line there, I cannot retrieve this for comparison from the hospital's electronic drive. So from what the radiologist is saying there is that they didn't have the actual MRI kind of disc to look at my previous report. So it seemed that only my report was available to the radiologist to kind of compare to. So they weren't able to kind of look at the previous findings, specifically with regards to the images, because it wasn't available to them for whatever reasons. I don't know why it wasn't available, but that's just important to keep in mind, as it wasn't a true comparison either. So now if we move into my axial images, guys, of the L5-S1 disc. So here's January 6, 2014 on the left, an axial view of the disc itself. And as you can see, we have some posterior lateral disc protrusion on the right side there. And if you pay attention to the blue arrows, guys, just kind of, if you look at the kind of outer shape of the disc there, I want you guys to kind of focus on those areas. And this here, guys, would be the S1 nerve root on the left, and then the S1 nerve root on the right would be in this area here, but we cannot see that as the disc is kind of blocking it. Now, if we look to my follow-up MRI now, on July 24, 2017, we see that left S1 nerve root right in this region, and then in this region would be the right S1 nerve root. We still can't really see it. Now, if we pay attention to kind of the outer lining of the disc here, this is where I want you guys to pay attention. We see, if you look and compare closely, there's been a little bit of regression in this region here. If you looked over here, specifically, see it's kind of bulging out a little bit more in this region. But if we looked here, we could see this little black dot, which is not an appearance really here. So that's just an indication that it seems the disc has regressed very subtly, but not much. And even here, we can see almost two little kind of black dots, which we can't even see anything there. And this is just an indication that there seems to be just a very subtle regression in the disc, and there hasn't been really any significant reduction and healing per se, one may argue. Now, if we blow these images up even bigger, and to kind of give you a more close-up view, if we pay attention to the same region here, we could see the disc protrusion right here on the right side. And then if we look to my follow-up MRI, if we blow it up, you could see that there's just been a very subtle little bit of a regression in this region here. There seems to be just a very subtle regression, which seems to have been enough to really take the disc off the nerve root and to kind of prevent any kind of radicular symptoms from occurring. And so now, one may ask, why has my disc not fully healed, especially after 3.5 years? It's been such a long time. So guys, an important takeaway is that it's complicated. It very is complicated, and there's a lot of factors at play here. And so one may argue more time may be needed. It may be a heck of a lot more time may be needed for disc injuries to occur. And the reason being is because we have very limited blood supply to the spinal discs, and really they only have blood supply to the outer 1/3 of the disc. And so since they are so avascular, there's just a limited amount of nutrients really getting into the disc, and healing may just occur at a very, very slow pace inside of the disc. But it's also important to consider, guys, the wear and tear after recovery. So sitting, hockey, weightlifting. So after I made my pain-free recovery, got back to normal activities, I started to get back to tasks like sitting, hockey, weightlifting, playing sports, playing basketball, all activities that are definitely going to stress the lower back, going to stress the disc. So as we're kind of stressing that area, we may be kind of delaying the recovery for the disc itself. And something that I was not aware of at the time, but it's something that we need to kind of keep in mind here, is just that wear and tear after recovery. Now, obviously, I manage things accordingly now, and don't put myself in risky positions, or I try to limit them as much as possible, and I just listen to my body nowadays. And if I ever experience maybe even just a subtle issue, I'll kind of take it easy, rest, kind of recover, and kind of ask myself why that issue may have occurred as well, and try to eliminate it for the next time. But now the important question too is, why and how did my pain go away? So it's important to keep in mind, guys, I had a postural related herniation, if we go back to things, and my pain triggers were sitting and bending over specifically. So anytime I bent over, I would get significant pain. So if we look to bending over now, what happens to the disc is that this area is going to open up, and it's going to push out, and it's going to further hit that nerve root, and it's going to cause more pain, and we're going to cause more damage to that nerve root in theory, the more we bend over and the more pressure applied, because this disc, this area here, is going to bulge out further, put more pressure on it. And I had positions of pain relief, stomach lying and standing, walking. So if I stayed in this position, the more I stayed in this position, I'm not going to be putting any stress on the nerve root. I'm kind of limiting the amount of stress that I may place, because I'm eliminating those pain triggers such as sitting and bending over. I'm staying in positions of pain relief such as stomach lying and standing and walking. So the more I stayed in those positions, the better I got over time, which is important to keep in mind. So when looking at this, when looking at my disc herniation and whatnot, it's important to keep in mind that it was postural related. And just by looking at an MRI sometimes, guys, MRIs have their limitations because you're laying in a supine position, and an MRI is taking images of you lying in a supine position. It's not taking you in positions where you're bending over or you're loading your spine under compression. So the key point to kind of take away is that it's sometimes, so oftentimes a lot of people's pain is mechanically related to their biomechanics. So certain positions are going to provide relief, certain positions are going to make things worse. And that was specifically in my case. So now it's important to keep in mind I had two types of pain that were specifically related to my disc, and that was the sciatica, the radicular pain that I had going down my leg, and muscle spasms, which is kind of more of a secondary cause of things just getting progressively worse. So we're going to touch on sciatica first. So to look at the causes, we have to understand why sciatica occurs. So there seems to be a mechanical and chemical role in the onset of sciatica. So the mechanical role would be more so compression. So compression, so the disc compressing the nerve root. So like I said, guys, my disc herniation was postural related. So every time I bent over, I'd be placing more compression on the nerve root, causing more damage and more pain. And we'd get this kind of chemical response as well. So we get the accumulation of various interleukin molecules, interleukin 1, interleukin 6, tumor necrosis factor alpha, and other inflammatory molecules, which could also be playing a role here in the onset of pain, as they may be playing some sort of role on the nerve root. Could be somehow significant accumulation of those molecules seem to be playing a role in the onset of pain as well. And you could specifically look to why non-steroidal anti-inflammatory drugs work in providing pain relief. So obviously there's a chemical role as well. Now, damage to nerve root and the death of nerve cells, so pain, tingling sensation. So as we get this compression, this mechanical compression and this chemical accumulation of a lot of these kind of inflammatory markers or other molecules as well, could cause damage to that nerve root and death of nerve cells. And that's how one may get pain down their leg and get tingling sensation in maybe their toes or feet. And this would be a result of, one reason would be a disruption of the axonal flow as a result of the nerve compression. So the more compression we're going to get, the more we're going to disrupt that axonal flow, which messages that are kind of sent down the nerve are going to be disrupted, and we may be limited in how those messages are being kind of moved down the nerve. And as a result of that disruption, we get problems such as that tingling sensation or pain. So now, if we look at this from a visual perspective, we have our bulging disc on the top, vertebral body, and then we have our normal disc on the bottom. So if we just look, if we draw a straight line down, we can see the disc is bulging on the posterior side. And if we were to draw two nerve roots now, we can see the bulging disc is hitting that top nerve root. And then on the normal disc, it's in a normal position. It's not hitting that nerve root. Now on that top disc, if someone were to further bend over constantly, like in my case, you're going to keep hitting that nerve root, and it's going to cause more pain. You're going to cause more problems to the nerve. And so we may get cell death, accumulation of those inflammatory markers, more pain, more problems. So when looking at kind of sciatica in itself, so what this would suggest is that as we're causing damage to the nerve root, we may need to heal the nerve as well, in addition to the disc, as should be a focus. But in order to heal the nerve, we need to take the pressure off that nerve from the disc, and that would involve having individuals stay in postures and positions that do not trigger pain. Because if they do stay in those positions that trigger pain, they're going to make their pain worse. And so now, a secondary pain that I specifically experienced, and this was a result of things just getting out of whack and getting really significantly back, was muscle spasms. So if we looked at causes, it was chemical, and in my case specifically, as it was more of a secondary reaction as things just getting really bad. And it being a potential secondary consequence due to some chemical factors, being problems at the neuromuscular junction, sarcoplasmic reticulum, muscle cross-brachial ion channels. Could be a number of issues going on with the muscles and why they're going into spasm. But I personally believe it's due to the high accumulation of a lot of these inflammatory markers, these interleukins, tumor necrosis factor, that may play some sort of role at some of these ion channels or along the sarcolemma, which could be causing that muscle to spasm and create significant pain. Now guys, the muscle spasms, in my opinion, were the most painful thing that I have ever probably experienced, and I believe that it was personally worse than the sciatica. I remember waking up in the middle of the night with muscle spasms, and it was just significantly bad. And the only thing that kind of provided me relief during this time was either heat or kind of non-steroidal inflammatory drugs or painkillers. So I didn't have these for a long period of time. It was just maybe for about a month to 2 months, kind of really in the initial early stages of my injury. And then as I kind of got a little bit better and started making progress, I never kind of had the onset of these again. So that's why I kind of believe that it is due to kind of the accumulation of these inflammatory markers, but there could be other molecules and there's a lot of other factors at play. But I just want to touch on kind of muscle spasms as a kind of a secondary consequence. And now, answering the question why and how did my pain go innate, now we understand how kind of sciatica occurs, how the muscle spasms occur. Well, the important thing, like I mentioned guys, was I identified my pain triggers and I removed them. And then as I did this, I got better over time. Mind you, it was a slow process, but over time I got better and got back to the point where I was pain-free. And so like I said, time, patience was very important in the process, just kind of sticking to those positions and avoiding those kind of pain triggers and sticking to the positions that were providing pain relief as best as possible. So like I said, it took about 1.5 to 2 years to be pain-free, but keep in mind the first 6 to 7 months were wasted with failed treatment. And one would argue that if I had good treatment from the start, could have made a recovery in maybe 1 year to 1.5 years instead of that 1.5 to 2 year period. Now, the question is, but my disc protrusion still exists. Well, the thing is that while my disc protrusion still exists, it could have just regressed to the point of no pain like I've showed on the axial images. There seems to be a little bit of regression, and it's just kind of taking the pressure off the nerve root. Another thing is the nerve root healed, so there was, in theory, there would have been damage to the nerve root because of that compression, so the nerve root has also healed, and there could have been changes in healing in the disc itself. So looking at the more internal aspect of the disc, there could be better hydration properties in the disc, and that's all things you can't really specifically measure, but there could have been kind of changes in the more internal aspects of the disc that maybe is leading to less accumulation of inflammatory markers. Like I mentioned, there seems to be a chemical role in the onset of pain as well. But just kind of, it regrets to that point of no pain. It seems to be kind of the big factor, at least what I speculate in my opinion. And if we just kind of touch on a more recent study, just looking and asking the question, does every bulging or herniated disc cause pain? So here's kind of a chart that I'm going to pull up. And it's looking at the number of patients by age used to inform the prevalence of a disc bulge and disc protrusion imaging findings in asymptomatic patients. So people with disc bulges and disc protrusions that are asymptomatic or have no pain. So we see age on the top, and then we have our imaging finding on the left as a disc bulge or disc protrusion. Then the parentheses or the brackets is going to represent the number of studies that they looked at. So if we just kind of pull them all up slowly, and if we look to individuals in their 20s, which is the category I would fall into with a disc protrusion, 87 individuals asymptomatic, and that was reported out of 5 previous studies that they kind of took from. But if we look to 30, 40, 50, 60, 70, 80 years old, we see all these people with disc bulges and disc protrusions that are asymptomatic and don't have pain. And it's a bit of a mystery why, and why this occurs and why these people don't have pain. But obviously a few reasons would be, is there that mechanical compression on the nerve root, the amount of inflammatory markers in the region, the amount of pain receptors in certain regions. So genetics seems to have a small role, and just maybe the ability to limit themselves from putting themselves in those pain-inducing activities, because their disc bulges and disc protrusions may be more mechanically related, and so they just don't have any issues or whatnot for maybe some of those reasons. But like in my case, guys, I would specifically fall in that category. So disc protrusions asymptomatic for 20-year-old individuals. So I'd fall into there based on kind of my results now, because I do not test positive for radicular pain or anything like that. Now, there's an important thing I wanted to touch on now with all this, and facet joint pain. So this is something, guys, I personally still kind of deal with some issues with regards to. And if anyone has ever asked me, do I have pain, have I made recovery? And I always tell them, yes, I have. But I do have some from time to time, I do have some complications with my facet joints. And so this is what I will cut out all these mention. It's just, I do have some complications here. And if we look to my more recent MRI, we could look that I still have some kind of arthritic degenerative issues going on at the L3, L4, L4, L5, and L5S1 with regards to my facet joints. And if we look to the causes of my kind of facet joint, I believe mechanical and chemical seem to both play a role in the onset of that facet joint pain. And so mechanical, compression, and micro movement. So what I've found that kind of may make my pain worse is if I'm sitting in a poor posture for a prolonged period of time, or I'm causing maybe a significant compression and I'm not maintaining a good strong brace through my abdominal region, and I allow for certain micro movements to occur at the joint, which kind of trigger the onset of my pain. So a perfect example, guys, squatting has been something that has been challenging for me to get back into, and it was specifically more challenging a few years ago, and it was because of having kind of this facet joint pain kind of trigger up and causing little flare-ups in my back. And what I noticed was that when I was not maintaining a strong, proper brace, if I were squatting, if I were to lose any kind of subtle stiffness in my brace when squatting, I would notice that I would get kind of just an onset of pain in my lower back. No, it wouldn't last long. It was just kind of a quick acute pain, and that was it. But I knew it wasn't good, and I had to kind of understand why that was occurring and kind of make the proper adjustments. But now, to this day, this only occurs from time to time. I mean, and it's not anything significant. It's very subtle. Things have progressively got better, in my opinion, and I know how to manage it properly. Is just kind of consistently developing the core, developing a strong core, but also learning to kind of maintain that proper stiffness during various activities that are going to induce compression specifically. And so the key thing is just when compressing the spine is to avoid those micro movements and maintaining that strong brace, which I found at least helpful for my case. And so just going back to the chemical, the accumulation of those inflammatory markers as well seem to maybe play a role as well when we get that onset of pain. And so what makes things better or worse with regards to my joint pain? So sleep. Sleep is a big thing for me, guys. If I don't sleep properly, I get a bad sleep, maybe one night or a couple nights in a row, I tend to find my joints flare up a little bit. Or not so much flare up, they just get a little bit cranky. And the reason being is just because when you're not sleeping properly, your circadian rhythm gets out of whack. So hormones are going to get out of whack, and you're not kind of following your normal rhythm. And so you may not be able to control inflammation as well. So not being able to control that inflammation could lead to that maybe onset of pain and cause the joints to be a little bit achy or cranky. And so I find just getting good quality sleep, I'm fine. And if I get a bad sleep a couple nights in a row or one night, and maybe the next day I'm planned to perform like a heavy deadlift or maybe squatting, I will normally cancel that workout out because just because I haven't slept well for the past night or past few nights, and I don't want to put myself at an additional risk for injury or to make things worse. Spine hygiene, this is another important one, guys. So spine hygiene is very important, and this is something that I'm always trying to maintain throughout the day. And so what I refer to spine hygiene is trying to minimize the amount of stress or trauma that you're putting on your spine throughout the day. So for example, the way I plan my workouts now, specifically for my case, is that if I have a workout plan for one day and for whatever reason prior to that workout I end up sitting in a meeting for a couple hours, or I'm standing all day or whatnot prior to that workout, I will not go, I either will cut that workout, I would either end up cutting that workout out or regressing it to something easier or lighter, or I would just kind of go take a long break in between to allow my spine to kind of recover a little bit from all that stress and trauma that I placed on it from sitting or standing. Because what I find is that if I were to go to the gym right after that, my spine has already been really stressed and it may not be able to take those high compressive loads, and I could be potentially causing damage. So I'm very careful with this in terms of maintaining that proper spine hygiene throughout the day, which I think is very important, and a lot of people need to kind of follow if they have kind of spinal issues specifically. Diet's another factor, guys. Now, I haven't really specifically noticed anything significant with diet, but it definitely has its role and has its factor, and it's something I want to include. For the most part, I eat a healthy diet. I'm not going to say I'm perfect, but I do find eating a lot of high vegetables, green vegetables, lots of fruits, do find that just to be very helpful for my body specifically, and I find I respond well to that. And so eating a healthy diet definitely, I think, has its role, but I do find sleep and spine hygiene play a very significant role in terms of trying to optimize that performance. And I feel that diet, one could maybe get away with eating a not so healthy diet if sleep and spine hygiene are maintained. Whereas if someone eats a very healthy diet and if they're not maintaining sleep or spine hygiene the way they should be, I feel like there could be some more issues there on that flip side. But exercise is another important factor here too, guys. I find exercise makes things better for me specifically, but also, it can arguably make things worse too if I were to perform bad exercises or bad movements. But just hitting the core hard, I found, has been helpful over the years. Specifically after I suffered my injury, I've just placed a significant emphasis on strengthening the core, strengthening my whole body, strengthening a lot of imbalances or weaknesses that had existed during the time. And I found that specifically when performing like heavy lifts now, I'm able to perform them fine without pain. And I believe a big part in that is just because I've strengthened my core to the point where I could handle that and create that stiffness and get that kind of muscle activation that I need to perform those lifts. So definitely exercise has its role as well. And I believe that strengthening that core also kind of prevents those micro movements at the facet joint. But that also comes back to learning to properly brace yourself and brace yourself accordingly to the certain tasks at hand. Now, a lot of you are probably asking, how am I able to deadlift 390 pounds? And so as you can see in this video, this is me performing a 390 pound deadlift. Now, don't mind the warm-up, guys, here, or me kind of preparing for it, just kind of stimulating my nervous system a bit and trying to get myself a little bit fired up before I go pick this bar up with 390 pounds. That's me just hitting 390. Wasn't perfect on the lockout, but regardless, I'm picking up 390 pounds after all those issues I had with regards to my MRI as indicated, but I have no pain or issues doing it. So why now? Technique's obviously one of the most important things, guys. Learning to create the proper stiffness and activate the certain muscles that are required for the deadlift that allows you to create that stiffness and keep your spine in a very friendly position per se, as opposed to rounding your back, which is a mechanism that is going to cause a herniation to occur, and which caused my kind of herniation to occur, which was the nail in the coffin in the early stages. So technique is critical for anyone that wants to get back to deadlifting, to get back to squatting safely, or any even sport for that matter. Maybe it's even like hockey, or maybe it's something like golf, where you may have to alter your technique because you have back issues, so you have to put your spine in a more spine-sparing way per se. So that's really important, guys, is technique when getting back to lifts and getting back to activities. Technique is critical. Now, foundational development, so developing kind of a foundational development for my body, core strength specifically, developing the appropriate kind of foundational strength and muscular endurance that I needed to kind of perform a lot of these lifts and activities was critical. So keep in mind, when I kind of made that pain-free recovery, I didn't rush back into lifting. I didn't rush back into hockey. I kind of took a whole year and a half per se to really just kind of develop a foundation, kind of stuck to a lot of spine-sparing movements, really hit the core, just kind of try to develop my overall body in a safe manner, and just kind of learn to develop in combination good technique with exercise, and then I was able to hit it, guys. So that's just kind of another important point that I wanted to kind of mention there, is that foundational development, but also proper recovery, sleep. So getting a proper sleep every night, if I get a bad sleep, or if I get a couple bad sleeps in a row, I won't go do a heavy deadlift or heavy squat, just because I know kind of my circadian rhythm is going to be a little bit out of whack, and my hormones are going to be out of whack, and I could be putting myself at a higher risk for injury. And then probably one of the most important points as well here is maintaining good spine hygiene throughout the day. So lying on my stomach, minimize sitting, like I previously mentioned. So to this day, I still minimize sitting. I hate sitting for the most part. I mean, especially when sitting for prolonged periods, I hate it. But so I tend to lie on my stomach a lot still these days, just to kind of reduce the amount of stress and to kind of allow for decompression of my spine, to kind of minimize that trauma. So I'm able to, when I go to the gym, when I go to lift, I'm able to do it efficiently and effectively. And I know that I've accumulated very little stress throughout the day, and I'm putting myself in an optimal position in terms of reducing the risk for injury, but also optimizing my performance as best as possible. So the key takeaway from all this, guys, is that everyone is different. Everyone's case is different, and no one can really compare one case to another, because no one's going to be exactly the same. Everyone's disc bulges, disc herniations, lower back pain, facet joint pain, stenosis is going to be different, whether it's left side, right side, the type of pain experiencing, their pain triggers, their pain-free positions, what provides them relief, what they respond to in exercise, their exercise program. Everyone is going to be different. Everything's going to be different for each individual, and not one's going to be the exact same. While there may be some similar cases that may be very similar, that's not going to be for everyone, and that's kind of the important takeaway. So that no one should be really comparing their own case. They should just be finding out what works for them best and kind of sticking to their recovery process as best as possible for what works best for them, which is the important takeaway kind of from all this, is that I wanted to kind of share with you. But the important thing, guys, is identify and remove pain triggers. If you have mechanical back pain, if you have something like a postural-related herniation or whatnot, it is always important to identify and remove those pain triggers, because that's what's going to allow you to get better, and it's going to allow for your system to make the necessary kind of physiological repairs to whatever damage may be occurring in your body or has occurred in your body, without kind of causing further damage. And that's why it's important to identify them and remove them. And so that's kind of probably one of the most important points I could share with you guys, is identify and remove the pain triggers. So I hope you guys enjoyed this webinar today, and that's all I have to share with you guys, and that's my MRI results. And I hope you guys kind of took some important points away, and it was educational for you. Now, it's probably not what a lot of you expected, because the disc protrusion hasn't fully healed, and it seems to only may have regressed to a very subtle extent, but to the point where I'm pain-free and I'm back to activities. Now, keep in mind, I could easily probably fall into a relapse per se, and be right back at square one if I haven't, if I kind of just pick up something the wrong way without, you know, maintaining a good spinal posture, which is always important to keep in mind. But that being said, guys, you know, pain-free, back to activities, back to just enjoying my life and whatnot, and trying to help others as well in the process. So if you guys, if this is your first time watching one of my videos and you want to see more kind of tips, be sure to subscribe to my YouTube channel. But if you also guys want to see more up-to-date things, you know, feel free to follow me on Instagram or Snapchat at Remi Sovran, which I'm kind of will post more things regarding around deadlifting, maybe training, or just kind of more things that may be personal in my life if you want to kind of see that as well. Okay guys, so that's it. I hope you guys enjoyed, and I wish you guys all the best, and take care.